My name is Sean Morrison. I am the chair of the Department of Geriatrics and Palliative Medicine, and on behalf of our faculty and staff, I'd like to welcome everybody to the 23rd Annual Douglas West Endowed Lecture Series. It's hard to imagine this has been 23 years because I've been here for every single lecture, and I'm not that old, but nevertheless, this is one of the highlights of our year at Mount Sinai, and particularly of the department's year. And I, again, want to thank the West family for endowing this very special lecture and giving us really an opportunity to come together to think about the needs of the seriously ill and older adults, and to remember Doug West. And I'd like to invite Susie to come to the podium and say a few words.
Welcome to all my family, friends, and my Mount Sinai colleagues. I'm Susie West. Every year we gather together for the Douglas West Memorial Lecture in Geriatrics and Palliative Medicine. We remember my husband Doug and honor Dr. Diane Meyer, who cared for him and our family while he struggled with a painful illness. When Diane and I planned the first Douglas West lecture, we talked about establishing a palliative care program at Mount Sinai. And here we are at the 23rd Annual Douglas West Lecture, almost a quarter of a century later. The work of Mount Sinai's Hertzberg Palliative Care Program, under the leadership of Dr. Sean Morrison and CAPC, which is the Center to Advance Palliative Care, founded by Dr. Meyer, touches the lives of patients and their families in thousands of hospitals and homes around the world. Our clinical services grow every year. This year, we have enlarged our supportive oncology services at Mount Sinai Hospital and Mount Sinai West, not named after me. Increased our inpatient team at Mount Sinai St. Luke's, and added additional support to patients and families in our ICUs. Every year, 140 students at Icahn School of Medicine at Mount Sinai partake in mandatory training in geriatric and palliative medicine. Mount Sinai is one of the few medical schools in the country to recognize that no student should graduate without exposure to the core knowledge and skills of palliative care and geriatric medicine. The students work with clinicians, doctors, nurses, social workers, and others in outpatient and inpatient geriatrics, inpatient palliative care consults, and home care. Of course, our goal is to have every clinician in the country aware of the benefits of palliative care for his or her patients and their families. Finally, after years spent educating Congress by Doctors Robert Butler, Diane Meyer, Sean Morrison, and many other members of our department, we are really hopeful that the Bipartisan Palliative Care and Hospice Education and Training Act will pass Congress and be funded this year. My life has been enriched by being part of this incredible team, and I am so happy that you are here today to support and celebrate our success now and in the future. Today we are pleased to have Dr. Al Su, Chair Emeritus, I have a problem with that word. Where is Dr. Su? Yeah, department, and one of the leading health service researchers in the country to talk to us about his vision for American healthcare. Thank you.
So for 25 years, Dr. Albert Su, Chair Emeritus, has been my boss. And so now I get to allow him to wait 5 minutes because I'm his. So I'm going to steal 5 to 10 minutes of his time. I typically don't do an introduction like this, but I do want to do a typical academic introduction for a number of reasons. Dr. Su was born in Havana, Cuba, and left there rather precipitously, not by choice, as a young man settling in California. He got a BA not with distinction, but with great distinction from Cal Berkeley, and then went on to do his internal medicine, or his medical school training at Yale, followed by internal medicine residency and a master's in science and public health at UCLA. 3 years after joining the faculty at UCLA, he became the division chief of geriatrics. I think he is still probably the youngest person ever to assume that title at any division of geriatrics or department in the country, and certainly only assistant professor ever to be thrust into that leadership position. He left his tenured job at UCLA in 1993 for what looked like another tenured position that was going to be Deputy Commissioner of Health for the state of New York. He came over under the Cuomo administration. As many of you remember, in 1995, that administration ended with the election of George Pataki, and he was out of a job. Fortunately for us, he landed at Mount Sinai, where he and then the former Commissioner of Health established the Department of Health Policy here. After that, he moved over to become Division Chief of General Internal Medicine, and it was under his leadership that the Mount Sinai visiting doctors really began and blossomed into the leading home-based medical care program in the country. And in 2003, he moved back to his home in geriatrics and served as the chair of our department until he stepped down to put Emeritus after his name in 2017. It is notable that of many of Dr. Su's accomplishments as chair, I think the singular one that he will be remembered for nationally is that he transformed what was a very traditional department of geriatric medicine into a national archetype that merged the fields of geriatrics and palliative medicine together. This department was the first department of geriatrics and palliative medicine in the United States. There are now, at last count, over 30 divisions that have changed their name from quote-unquote geriatrics to geriatrics and palliative care to recognize the specialized needs of seriously ill older adults. He has more honors than I can count. He is a fellow of the National Academy of Medicine, which is one of the nation's highest honors for people in academic medicine, and also holds the Jacobi Medallion, which is Mount Sinai's highest recognition for its community. He didn't retire when he stepped down. He just took an office with a better view, and now runs the very innovative Mount Sinai at Home service line for the Mount Sinai Health System. And it is truly a great, great pleasure to welcome my former boss, Al Su.
Thank you, Sean, for that too long introduction. And thank you for all of you for coming to the West family. You know, Susie's been a family member, you know, of the Department of Geriatrics and Palliative Medicine as long as I've been there. And for your support, you know, of Mount Sinai and the department. Thank you for all of you in many ways. You know, some of you are my colleagues. Thank you for being here. And for the rest of you who've been part of the geriatrics and palliative care family here at Mount Sinai. Today, what I want us to try to do is spend a little bit of time reflecting on what I believe, you know, to be missing from the toolbox, or the medicine cabinet, if you will, of American medicine. And it seems like an apropos time to be doing that. These issues are bubbling up once again. As in the last midterm election, they will bubble up again in the coming presidential election. If you saw the headline in today's New York Times, you know, the president plans to bring up the repeal of the Affordable Care Act again, you know, if he captures Republican control of the Congress. So we are going to be talking a lot about these issues over the next couple of years, probably. And I want to spend a few minutes, you know, with you today, you know, giving you my thoughts on what we need to be doing going forward. But before that, I want to preface that by talking to you about what I think is right about American medicine and what is in our medicine box that works very well. And that is that we do cutting-edge care very well in this country. Under other circumstances, I would not be alive today to speak to you, but for cutting-edge care that we provide in the United States. At the age of 28, when I was a third-year medical resident at UCLA, I began my third year with a summer cold and developed, some lymph nodes in my neck, as one often does, with a summer cold. I approached my attending physician on my rotation with it. We didn't think much of it. A few weeks went by, my nodes continued to be tender and hurting. We still didn't think much of it, but we decided to go ahead and get an excisional biopsy of those nodes, of one of those nodes. Still, nobody thought that this was anything, really, and that it was only because I was a medical resident, that we were going to all this trouble. A few days later, during a lull in our clinical rounds, I decided to call surgical pathology to get the results. Because that's what the residents did in those days. We ran down lab tests, we ran down results. They didn't come across the electronic medical record like they do today. So the clerk in surgical pathology, thinking that I was the doctor, not the patient, told me that my biopsy results were consistent with Hodgkin's lymphoma of mixed cellularity type. Now, there are a couple of lessons there, and broken rules here. One of them is that physicians should maintain some distance from their own care. And I think that the second important lesson, that the palliative care and the geriatrics fellows in this room know, is that this is not the way to break bad news. We've been taught how to do that. There are protocols for doing this. There's the environment, the setup in terms of how we break bad news in the environment. This was not the way to do it. But be that as it may, I went through, got the diagnostic testing, got surgical staging, as we did in those days for Hodgkin's lymphoma, and began my treatments. And the plan was for me to do as much of my residency rotations as I could during those treatments. That, of course, lasted one day, because after my first treatment, I remember running out of rounds to vomit. And that was, the end of that plan. But I got treated successfully. I've been in remission ever since. And this is an example of one of the things that we do well in American medicine in terms of providing cutting-edge, science-based treatments that in many ways, the protocols for these treatments for Hodgkin's lymphoma were developed in the United States. And as we talk today about what's missing in our toolbox, we have to remember that this is one of the things that we want to keep in that toolbox going forward. Now, there are many things, that are seriously, wrong with American medicine today. Somehow, we manage to provide the most expensive care on this planet, yet receive lackluster results from that, and do it in a way that is most unequal in terms of the outcomes that result. If we were in the car industry, it would be as if we were producing an expensive product that was lackluster and unreliable, and nobody would buy it. Think of it. So let me take you through, how we are expensive, how our performance is lackluster, and how we are unequal. Cost, okay? We spend 18% of our gross domestic product in this country on healthcare. That in and of itself, is not bad, okay? If we've got good results. If there are banks that are too big to fail, we have become an industry that is too big to mess with in order to fix. If you've seen, comments about Medicare for all, okay, the general consensus, among some has been that the industry is simply too big for us to be making drastic changes. We spend approximately more or less about $10,000 per capita in this country on healthcare. That is 2.5 to 3 times what they spend per person in the UK. Not 10% more, not 25% more, not even 100% more, but 2.5 to 3 times more than they spend in the UK. And, at the same time, our life expectancy in this country is really at the bottom of the class of the G7 nations. Canada, Western Europe, Japan. Indeed, our life expectancy, ranks 32nd or so in the world, right, nip and tuck with life expectancy in Cuba. That is what, our 18% of the GDP, buys us. So our care, is expensive, and our performance is lackluster. And it's not explained by a variety of reasons. It's not explained because we're more diverse. People have said, well, it's hard to compare us with Denmark. True, okay? But if you just do the analysis looking at whites in America compared to whites in the UK, you get the same results. They are healthier in the UK and spend a fraction of what we spend. If you, take into account geographic distance to the doctors, okay, and our population density, okay, the results look the same when you compare us to Canada. If you take into account smoking levels, alcohol consumption, obesity, of which we are also off the charts, okay? But if you take all of that into account, we are still off the charts. We're still off the charts if you take into account education. We are, in the running in terms of how much hospital care we use relative to the rest of the world. We're in the running and no different in terms of the number of doctor's visits. What, we are off the charts on is on prices. We pay our doctors and our nurses more. But that doesn't really explain life expectancy, if you think about it. So I would argue, that we have a problem in terms of how costly we are and in terms of the lackluster performance that we get, as a result. But we are also highly unequal in this country in terms of what we accomplish. We consider ourselves, one, and we travel with the other G7 nations. We share, standard of living with those countries. We share in many ways the same philosophy of governance, with those countries. Yet, when you look at indices of income inequality, these are indices constructed looking at the 75th percentile of income compared to the 25th percentile of income, okay? We're not in the company of the G7 countries, all of which have less inequality than we have. We sit in the company of Saudi Arabia, South Africa, and a number of Central African republics in terms of where we stand in inequality. You can look this up yourself in the CIA handbook. Okay? They list by country, you know, our inequality indices. And what we have come to realize is that inequality in income also translates to inequality in health. If you take a look at the life expectancy of 40-year-old Americans and compare the 1% poorest to the 1% richest at the age of 40, there's a 15-year difference in life expectancy at the age of 40. Now, you could say, I'm just looking at the extremes, okay, of, you know, the 1% poorest compared to the 1% richest, you know, but it's linear, the relationship. Our multi-billionaires have better life expectancy than our single-digit millionaires, who have better life expectancy than the middle class, who have better life expectancy than the lower middle class, who have better life expectancy than the poor. I think that this is an issue that should concern us in this room. And not only that, as we all, you know, have known for a number of years, there's growing inequality in this country, such that, you know, from 2000, the year 2000 to today, the gains in life expectancy that have occurred have almost all been in the wealthy. Among the poor, there's been virtually no gain in life expectancy in the United States. So I believe, you know, that our system is seriously broken. You know, we provide expensive, lackluster, and unequal care. Now, how do we get this way? What I want to share with you, you know, is my theory of how some of this stuff, you know, has happened. And my belief is that part of it is that, you know, we have grappled valiantly and struggled with balancing three very important American values, and not always successfully. Okay? One of those values is our belief in cutting-edge care. The second is our belief in freedom of choice. And the third is our belief in equality. All of which I believe, you know, are noble and right things to do. But they're exceedingly difficult, you know, to reconcile. Let's take each of these in turn. Okay. We excel at cutting-edge care. We develop, you know, very innovative pharmaceuticals, many of which did not exist when I was in training, that can effectively manage a number of conditions that we did not have good treatments for when I was in training. We have great imaging procedures. We have great surgical procedures, you know, including many percutaneous things that we did not have, you know, when I was in training. These are all great cutting-edge interventions, you know, that I am a beneficiary of. And if you take a look at international comparisons, we use more MRIs per capita. We use more, you know, hip replacements and surgical and invasive coronary procedures per capita than anybody else, and that's what distinguishes us. We all have smartphones. It is ingrained in us, you know, to love cutting-edge technology. The second one of those values is freedom of choice. We believe in being able to choose our health plan. We believe, you know, in our right to decide, you know, that we don't want to participate in the insurance mandate, as bizarre as that may sound. We believe in our ability to choose our doctors, to choose our hospitals, okay, to choose our treatments. We bristle if an insurance company denies, you know, coverage. we don't like, guidelines that limit how often we get mammograms, or when we start, or whether we get PSAs. And I've been on the receiving end of some of the criticisms, of that work, even if that is based, in sound science. And finally, the third value is that we believe in equality for that cutting-edge medicine, with freedom of choice, which we practice the equality piece, fairly well, under most circumstances, with some exceptions. But the reality of equality is that healthcare in America is actually quite separate and segregated. Now, that is not an explicit, decision to segregate. It comes about because of differences in insurance plans, in insurance design. It comes about because of where people live and their personal choices in terms of where they choose to get medical care. But some examples, okay? We expanded Medicaid, created Medicaid to extend equality and care to the poor. But because we don't pay very well in Medicaid, only about 30% of physicians take Medicaid in this country. And of the rest, many, limit the number of patients that they will take with Medicaid. We have physicians who don't participate in Medicare, even though every physician who's been trained in this country has had their training subsidized by the Medicare program. I find that outlandish. We have people, who we have networks. Your doctor or your hospital may not be in network. That's how the separation and the segregation happens in this country. And we also have, patients who may choose, to receive care, from certain types of providers because of cultural, reasons or for living results. As a result, income and race affects where you get your medical care in this country. It affects what doctors you see, what nursing homes you go to, what hospitals you go to. Some would say, well, separate might be okay. After all, these are market forces driving it. It's patient choices driving it. Why not in this country? The issue that I have with this is that we now have abundant evidence from a number of studies that separate care is associated with different outcomes in terms of mortality, readmission rates, the patient experience, and patient satisfaction. Separate care is unequal. And we see this across the lifespan and in different settings. One of our faculty members in Health Evidence and Policy, Elizabeth Howell, wrote an editorial about 2 weeks ago in Pediatrics that looked at how in neonatal intensive care units, race makes a difference in terms of which one you go to. And that which one you go to, depending upon your race, affects mortality and survival of little babies. We have known through a series of studies in the Medicare population at the other range of the age span, that race makes a difference in terms of where people get their hospital care in this country. And that there are subtle but small differences in terms of mortality, in terms of where you get your hospital care, with non-white populations tending to receive care in hospitals with worse outcomes in terms of mortality, readmissions, and other complications. And that sometimes these differences even occur within a hospital. Our colleague Vince Moore who sits on our advisory committee, for the Pepper Center, has shown that this extends to nursing homes. Race affects where you get your nursing home care. And non-whites tend to receive care in nursing homes with poorer staffing ratios, more citations, and other evidence of a poor quality. So the issue of separate and unequal extends across the lifespan and across settings of care in this country. Thus, I think, that it is the difficulty in balancing these three values, our interest in cutting-edge care, our interest in freedom of choice, and our interest, in inequality, that makes, it so difficult, and why we are currently providing care that I believe is costly, lackluster, and inefficient. It's difficult to provide cutting-edge care with freedom of choice to get, whatever you want at any time without it being costly. It's difficult to provide unfettered free choice to the latest pharmaceuticals, still on patent, being pushed, on consumer-directed advertising, and with physicians being encouraged to prescribe certain things without creating a prescription for problems. As we have seen, with OxyContin, and issues, most recently. And I believe, that separate and unequal is really one of the key factors, in terms of why we also happen to have lagging performance, in terms of our health outcomes, such as life expectancy. What's the evidence for that? As I've tried to show you, separate leads to, unequal, in this country, and that I believe, will be linked, can be linked to the decreases in the life expectancy that we see. So let me give you an example, okay? If you take a look at nations in the EU, in the European Union, you will find that they differ in terms of their disparities in terms of life expectancy by income. Some will have wide disparities, some will have narrow disparities. In Estonia and Hungary, there are relatively wide disparities, with the rich having long life expectancy and the poor having lower life expectancy. On the other hand, at the other end of the EU, in Scandinavia, those disparities are smaller, with the rich having, yes, better life expectancy, and the poor still having, worse life expectancy, but the gap is smaller. And there is the full range, in between, in terms of the EU countries. But look at this graph in front of you and make some observations. Okay, my son is in the front row, and he knows his statistics, from AP Stats. So you can make some observations here. Okay, on average, whose life expectancy is lower? That with the larger gap. And that is partly because Norway got to a narrow gap, okay, not by, decreasing the mortality of the rich, but by improving the mortality of its poor. And that the gap between the rich in Estonia and the rich in Norway is actually fairly small. And that the gap is really in the poor between the two. That is why I say that disparities, okay, in some ways drives the poor life expectancy, that we may be seeing in this country. This is my poor man's PowerPoint. Sean doesn't pay me enough. My son is probably, under his chair at this point, So I wish he hadn't done that. Excuse me, let me, I have, my spring allergies have kicked in. So what's the way forward, if that's the case? If we believe, that these values, in terms of cutting-edge technology, freedom of choice, and equality, are driving, some of the problems that we have in terms of cost, lackluster performance, and inequality in this country. Okay, one of our options, well, we could compromise on those values, but I would argue that that would never fly in this country. We believe, in our high technology, and that this would just never work. We believe in high technology and cutting edge work, and this would never work. It's as if, have you been on planes recently? You can barely get people to put their phones on airplane mode until the very last second. Okay, we do not want to give up, our gadgets in this country. You would hear talk of death panels all over again, if we try to do that. Similarly, I don't believe, that we can restrict choice in this country. Many of you will remember Harry and Louise commercials, that killed the Clinton healthcare reform. Okay, they will come back if we try to restrict choice. What I believe that we need to do is that we need to take these core values of ours, which I believe are good, and redirect them. We want cutting-edge care, okay, but we also want awesome performance on the fundamentals of care, which we fail at. We want freedom of choice, but frankly, those of us in geriatrics and palliative medicine have not done a good enough job in terms of disseminating and scaling, the things that we've developed to give people real choices in most of the country. And finally, I think that we need to get serious about inequality in this country. So let's take, each of these, in turn. We excel at cutting-edge care. Okay? But we do not do well at the fundamentals. I would argue that the American people want not only home runs, but a team that excels at bunting and fielding as well. We may do well with cutting-edge care, but we don't do well treating hypertension. We know treating hypertension works. It saves lives, it reduces strokes. In the latest studies, some would have you believe, and I may get there, that it reduces your chances of getting dementia. Effective hypertension control. But currently in this country, we have only about 25% of people with hypertension are controlled. If you happen to be on treatment, that number is 50%. Prenatal care. 1/3 of women don't get prenatal care in the first trimester in Texas. We need to do better on that. We don't do well in terms of asking, advising, and acting on smoking cessation in this country. I think those are all the fundamentals that I think that we can do better at. Kaiser, taking a much more population-based approach that doesn't wait till the patient shows up in the doctor's office, has shown that you can get from 50% of patients on treatment to 90% of patients on treatment controlled in terms of their blood pressure. That's pretty significant, I think. Other fundamentals that we need to get good at is that we need to be good at, controlling symptoms, in patients with serious illness. We've talked about that in previous West lectures. And we also need to get good at public health measures in this country, dealing with guns and obesity. These are the fundamentals that I think, that we need to do in addition to cutting-edge, treatment. On choice, choice is ingrained in Americans. This is something, that is so fundamental. We have, developed innovative models of care in geriatrics and palliative medicine. Diane, who's with us in the back, has done, work in palliative, in inpatient palliative care and in its dissemination, and its work here. We have done groundbreaking work in terms of geriatrics, patient-centered medical homes here, led by Audrey Chun on our faculty. We have done, work in terms of home-based primary care, started by Jeremy Bowl and now led by Linda DeSherry, as well as Teresa Soriano, her predecessor, who's here in the audience as well. Linda and I, have done groundbreaking work in terms of trying to launch hospital at home, in this country. But all of these innovations are not disseminated, although we are trying, okay? And that's what we need to do. They are available to some extent within our Mount Sinai health system right now, but if you go to the average hospital and health system in this country, you cannot avail yourself of hospital at home, of home-based primary care, of geriatrics ambulatory care, of effective palliative care. Those are the things that we need to do. We need to give people the ability to choose those options. We have not done that, up to this point. And finally, I think that we need to get serious about inequality. And in that, improving insurance coverage is the front line. We started out, before the Affordable Care Act, with 17% of Americans not having insurance. Today, that number is 10%. Okay. We need to do even better than 10%. In the rest of the G7 nations, that number is 0%. Our comparator nations all have insurance, universal coverage. We need to get there. Some call it Medicare for all. Medicare for all means different things to different people. But I think some version of Medicare for all that tries to move us towards universal coverage is the front line in terms of trying to deal with inequality, in our country. Not only that, I think that we need to move away from multiple payers, all of which pay different amounts. Some are good payers, subsidizing the care of poor payers, and in that way, rationalizing separate care. That's how it happens. If we can't go to a single payer, I would suggest that we at least need to blur the differences in the amounts, that payers, pay. Not that dissimilar from what they do in Germany, in the Netherlands, in Switzerland, where there's still private, insurance companies that are centrally, funded and regulated. We will not eliminate inequality. Okay, let's be clear-eyed about that. That's not going to happen. But there's much that we can do to mitigate its effects on health. By addressing, some of the income, education, and other issues, by which they work to affect health. Some have called, in our field, and we now call these the social determinants, of health. And in that, there have been a number of interventions, that have been developed to improve things like health literacy. There are interventions that have been shown to work in terms of, going to the homes of elders with disability and providing handyman services to improve their function, and which have been shown to reduce readmissions. There was a study, done in Virginia last year. That was one of the most highly rated papers read on health affairs that showed the value, of delivered meals for selected patients who had food insecurity and were at risk, and how that reduced hospital readmissions. And there is talk among, hospitals and health systems and developers of electronic medical records that we need standards by which we can put into electronic medical records key variables to collect information on the social determinants of health, on issues like food security, income, caregivers, et cetera. And the good news is that health systems, are beginning to respond to these issues because they are beginning to take on financial risk for these populations. I don't care if that's the way by which we do that. Our geriatrics and palliative care programs, in many ways, do many of these things already. We already integrate, the effects and understand what happens to caregivers. We already, integrate social aspects, into what we do, in medical care. We have been going into the homes, in hospital at home, in Mount Sinai visiting doctors, providing home-based primary care, in community-based palliative care programs that Sean and Nate have been leading. And in the home, you get to see firsthand whether or not there is food security or not, insecurity. You get to see, whether or not medications are being effectively managed or not. And you can begin to address some of the social determinants of health that are actually fairly hidden when you see the patient in the hospital or in the clinic. And so in summary, I believe that, yes, we do need to excel at cutting-edge medicine. Okay? I am glad to be here with you as a result of that. But we also need to commit ourselves to the fundamentals in addition to the cutting edge, in terms of being able to treat hypertension, in terms of being able to deal with smoking cessation, prenatal care, and things like that. I think that we need to honor choice by providing real choice, by creating alternatives in most American communities as they relate to palliative care, hospital at home, home-based primary care, community-based palliative care, and other options, that we have been developing here, at Mount Sinai. Diane has led the way in terms of trying to do that for disseminating palliative care. We are trying to do the same, for most of these, other interventions that we've developed here at Mount Sinai. And finally, I think that we need to get serious about inequality. So in a few weeks, in May, it'll be the 65th anniversary of Brown versus Board of Education, which ruled, that separate schools were inherently unequal and violated the Equal Protection Clause of our Constitution. Arguably, I would, make, the claim that Brown versus Board of Education may have been the most effective and important intervention that we've made into the social determinants of health in the last century. Albeit, incompletely, it has done, much to improve educational levels in this country, thereby, employment opportunities and income, which I believe will have in turn affected health. So 65 years, after Brown, I think that we have to come to grips that healthcare is separate, and that healthcare in this country is also unequal, and that we need to do better. And we can do that by beginning to address first the issue of coverage in this country, in terms of securing the gains made in the Affordable Care Act, and then going further. We have another 10% of people without insurance in this country. And that because things will never be equal, okay, that we as healthcare professionals need to mitigate the effects of inequality in this country through a variety of interventions. Some steps to get there, are already at our disposal, and our field has developed population-based, methods, to improve care. What we have been doing in terms of taking care into the home, in the way of palliative care, in the way of geriatrics care. Research that has been done in terms of the social determinants of health. This work has been done. It's been developed and tested by those of us in our field, and I believe that it's time to implement them and scale them and to disseminate them. In order to achieve care that, while still costly, I don't mind spending 18% of GDP on healthcare, given what we might spend it on instead. Okay? But that hopefully we can get, performance that is commensurate with the amount that we're spending. And that we can come closer to reaching our aspirations of equality. Thank you.